Okay. All right. We are back. What is it now, Joey? Episode 23 with the Gwen Effect podcast. We have the couch back, so I hope you guys are happy for the ones that are watching on YouTube. We had a lot of guests come in and feel like it was more of a sit-down interrogation rather than a couch comfort podcast. Although, Gillian, I think the first time I met you, I put you in a little bit of an interrogation. And
That's true.
Sorry.
You remember that? I didn't know if you'd remember
sorry,
that.
Not sorry, I guess. So, guys, Gillian has worked very closely with my daughter, Gwen, when she was in the NICU here in Kingston. She is a neonatologist. And the first time I ever met Gillian, Gwen was due for her second operation, I believe. Mm-hmm. And the night before, I remember sitting down in the basement with my little journal and my pen and writing down a bunch of questions to ask a neonatologist. I Googled that, by the way. Now you could just chat GBT it and what are some questions. But anyway, so I did. And I remember a little bit going into the room off the NICU, sitting down with my family and you guys. And I think there was some, I don't remember who was all there, but I do think surgical staff was there as well. And I bombarded her with a lot of questions. So I do apologize for that. And I promise it won't be like that today. But without further ado, I would love to introduce to you one of my many angels on earth again is Gillian.
Thank you so much, Tamara. It's really a privilege to be here today, despite being nervous. But
Good. We're good.
It's funny you brought actually that moment up because in preparing for today, I actually thought about our interactions and that first time I met you and how incredibly difficult it was.
Yes, that was a bad day.
So actually I have I think we'll get to it a little bit later, but a little bit of in talking about our decision making and why I'm motivated to do my job. So like you said, I'm a neonatologist. So that's like ICU for babies, for anyone who doesn't know. Usually what I say to parents and families and even my own parents when I told them what I was going to be when I grew up, was the sort of like that way, like a baby ICU. But I don't like grown-ups and sick grown-ups particularly. They smell bad. It's really sad and depressing. And I knew really early on in my training that I was not interested in taking care of grown-ups.
Wow.
So then it was just figuring out what kind of kids. And I am motivated a little bit by adrenaline and intensity. And
there's a lot of that.
Gives that.
Now,
does.
I guess how I've summarized it to people, because I'm like, we have a neonatologist on. They're like, okay, that sounds like a big deal. And I'm like, she grows babies essentially outside of mommy's tummy. And I remember seeing Gwen was 2.5 pounds, which I mean, gestationally wise, she was okay. Like she was a little bit plumper than most.
Yeah, she was big.
I thought when she was tiny, I thought she was tiny, but when I seen ones coming in that weren't even a pound yet, I go, how in the fuck are they going to do what they do? And I still keep in contact with those parents that did come in with pound babies or not even there, right? So many grams and that kind of thing. So that's funny because our first question was, what inspired you to become a neonatologist? So we were obsessed with the babes. So did I read in your bio you worked a little bit at CHEO?
So I did all my training after medical school in Ottawa at CHEO. So they have 3 sort of big centers there. And so doing my training, I worked in all of them. So the differences between NICUs are really if you have your baby there or you don't have your baby in that hospital. So the Children's Hospital of Eastern Ontario, there's no adults or maternal medicine or OB. So you deliver your baby at a different hospital and then get transferred to CHEO if you need it.
Yes.
But in the hospitals that deliver babies, there's usually a nursery.
Do sick kids deliver babies?
Nope. They come from Sinai normally.
Okay. I do. Okay. Yes, that makes sense. Now, I guess as what a typical day, what would it be for you? Clock in, clock out, if that's even a thing for you.
So we actually just changed our model here in Kingston, and now we have a neonatologist in-house 24/7. So when Gwen was born, we did what's called home call. So there was always a neonatologist available.
Yeah.
And during like regular people hours, so 8 to 5, they would be in the hospital.
Yeah.
But after hours and on the weekends, that wasn't the case. We would be at home and we would sleep at home.
Sorry, Gillian, do you have to live an approximate area around?
Yeah, it's sort of an unwritten rule.
Okay.
And it varies a little bit depending on your specialty.
Okay.
So for neonatology, we have to be sort of within 20 minutes of being in the hospital.
Okay.
Mm-hmm.
Okay.
But now it doesn't matter because we're there all the time.
Yeah. Yeah.
Mm-hmm. So but a typical day would be if I'm the attending neonatologist in the NICU, I get handover at 7:30 in the morning for whatever happened overnight from the nighttime neonatologist. I usually pre-round, which means checking on their labs, talking to some of the nurses, how was baby's night, checking on the sicker babies. So if they have a breathing tube or not, those usually how we classify the sort of sicker ones or more unstable ones. And then meeting with the team. So our team is made up of nurses, respiratory therapists, dietitians, pharmacy, social work, and residents. So doctors who are training to be pediatricians.
Yes.
And then medical students.
Okay.
And usually depending on the time of year, we have nursing students as well.
Yeah.
So we sort of huddle together before we start rounds and sort of come up with a plan for the day in terms of like, are we expecting anyone to be born? Does anyone need to go to MRI or something like that? So we can come up with a plan of who's going to do that. Because as I'm sure you can remember, moving Gwen for anything took an hour.
Oh, yeah.
Each way.
Absolutely.
So it's always a big sort of plan and discussion.
Yes.
And then we would round. And then after rounds, I usually talk to parents, write notes, do teaching with the learners.
Yeah.
And then hand over to the night person. So that would be a typical day when attending on NICU. But there's 7 of us now. And so I only do 14 weeks like that a year.
Okay. Mm-hmm. Okay. So, wow. I mean, and that's just a typical day. So that's so busy. But on top of the unexpected deliveries, things that could go very wrong very quickly. And I remember that, Desiree coming to me and I was feeling so defeated. And she's like, no. This is like a moment by moment thing. This ain't like a day by day. This is moment by moment. Yeah. So just prepare yourself for that. Right. Mm-hmm. And it was very much
up and down.
Yeah. I guess, saying that, what are some of the most rewarding and challenging aspects of the career that you have chosen as a neonatologist?
That's really hard because I think it depends on sort of the stage you're in, but also the kind of day or
How many years
have
you been in this position for?
So I've been an attending neonatologist in Kingston for 6 years.
Okay.
And I worked.
So you were fairly new when Gwenny came.
Okay. Because she was born in 2019
and 2019.
Yeah, so I had been there for just over a year.
Okay.
Mm-hmm. And I had done a year in Ottawa prior to coming here.
Okay.
And so not a whole lot of time.
Yes.
However, I did do a very long fellowship. So I did extra fellowships.
Okay.
In trying to figure out exactly what I wanted my full career to be, because neonatologist and clinical work is just one small part of our sort of academic responsibilities when you have an academic appointment. So I have to do so much teaching and research and sort of administrative roles and positions. Yeah. So a lot of people will choose sort of one of those areas as their focus, if it's education or research or administration. So by administration, I mean like leadership. So like you run the department or the division and things like that. And so I spent a little bit of extra time in training trying to figure out what I loved and what I did want to do kind of every day. I wish I could only do clinical work. That's what I love and my passion.
Hands-on, right? Yeah, absolutely.
It's just really, really exhausting physically and emotionally. And and you do need rest and sort of recharge. And so you do need something else on top of that.
Yeah. And I think, it's so amazing that you have that ability to keep learning as well. So you have to, yeah. Like it's forever changing and it's science, right? I mean, that's what we hope for anyways.
Absolutely.
And you teach at Queen Queen's University.
Yep. Mm-hmm.
First year med students?
So I teach very little in first and second year.
Okay.
But I am the clerkship director. So
Okay.
I'm part of the leadership that runs the last 2 years of medical school.
Okay. So would you say, like, going back to that question, what would be like the most rewarding part of your career? I mean, I could see some of the things like being able to like grow this baby and having them discharged is such a beautiful sight to witness.
Yeah. So good outcomes obviously are going to be
Yes.
very rewarding.
Yeah.
But I think it's really what you or the family or patients define as a good outcome.
Yeah.
Because to some people, that's, you know, as terrible as it sometimes sounds, is having your baby alive and in your arms for 10 minutes.
Yeah.
Whereas to other people, it's survival to go home from hospital with, you know, no consequences of being
so
born
true.
premature or with whatever diagnosis has
true.
happened. So I think, you know, what's rewarding is when I see parents get the wish that they want, and whatever that is. And one of the challenging parts of my job is trying to navigate that journey with them so they can figure out what that is.
What best looks like that.
And then how we can support them to get there.
Absolutely. Because I think, you know, preemies, those milestones are so much, so incredibly different. It's, you know, it's not necessarily like the first step, because some don't ever get that first step. So you really, you're kind of thrown into this abnormal world. Well, until you're in it and it's not so abnormal. It's like, okay, this could happen, right? And I think what was so frustrating for me, and I know other parents that were in my position, is as a preemie, there's really, you know, you have your onset things like brain bleeds and different obvious, well, not so obvious, but I guess what I'm trying to say is you can't predict. Gwen had a grade 4 bleed. It was very intense, everything she went through. And she ended up running, you know, and climbing and doing all these things. But she was also at a very high rate of having cerebral palsy. And I remember saying, well, what are the chances? And you would say, we don't have.
I don't know.
We don't know. And how frustrating that was for you too. Like, I don't know. I've seen children have grade 1. You know, and end up not being able to walk. And I've seen children have grade 4 and being able to walk successfully. So it's that waiting game, you know, and so, yeah, I definitely can resonate with you say like, well, what is the parents wanting and wishing? And because it differentiates. Sorry,
and depending on
difference,
what's happening in their NICU stay, could obviously be evolving as well.
Oh,
and their hopes changing. And that's
constantly.
Also part of us trying to navigate.
Yeah.
That.
I remember the one night I went in and I was like, I'm going to put her on comfort care. Like, I think I was just so exhausted. And by this time, there were so many times that Gwendolyn was near death, essentially, at this point. And I was just so exhausted, and I was so exhausted for her. And I think the whole disassociation for me kicked in, and I'm like, we got to do this. This is the best option. And Sarah was actually like the one, no, you know, we're not. And it just happened so fast. She's like, do you want to hold her? And I'm like, what the fuck? I can hold her? Like, this was after 10 days. I can actually hold her. Yeah. Okay. And I remember that moment, her going into my arms. And I'm like, hey, we got this, babe. It's you and I. We got this. And that was a whole new fight. You know, I was in that moment of, I'm tired. I'm giving up. You're tired. I can see this. Yeah. And then it was, so it does. It's constantly changing. I guess, like, you know, you've only been in this career. I say only, but what, 6 years you said? Has it evolved since you've been?
So it has. It's when some of the questions you sort of sent in preparation were like, what's the future and what has changed and what's new? And even just thinking about because I graduated from medical school in 2008. Okay. So even just thinking back to my own training and what I was doing then, like it's not 100% different, but it's pretty different already.
Where do you think it's changed the most?
So neonatology is a funny field, though, because it also like really doesn't have a lot of history itself. It's a relatively new field. And so with that, there's obviously going to be a lot of changes. But I would say the biggest and the one that is going to continue to change so much is with respiratory breathing management and how to optimize that. So there's still so many unanswered questions and there's still so much variability between centers and countries and what people are doing because of how we interpret the evidence and how we, are looking for ways to have better outcomes. So trying not to intubate any babies anymore trying to give surfactant, non-invasively.
What is that?
So surfactant is the liquid medicine that we give into the lungs.
Okay.
It's a fatty substance.
Did I receive that when I was in labor?
So you got steroids.
Yeah, it really hurt.
Yeah. Injection. Yeah. So, and they're even doing new studies on that now, what the optimal dose is, because that study was done back in the 70s, the one that we use and the doses that we use. So there's a huge study just starting now called the SNACS trial, looking at how many doses those moms should be getting to have optimal effect without any side effects.
Yes.
But surfactant is a substance that we all make in our bodies. It's in our lungs, and it helps the lungs stay open when you breathe out. So when you then take another breath in, your lungs can open and fill really easily. But you don't actually make that until you're about 32 weeks.
Wow.
So every baby born early doesn't have it. So it makes the sort of breathing diseases of prematurity even more hard to manage when the lungs completely close every time they breathe out, because then we have to sort of use a lot of force to open them up again. So surfactant was actually discovered a long, long time ago. But it wasn't until JFK's son died of prematurity and respiratory distress syndrome that they actually put money into producing it and properly studying the drug.
Wow.
So it's fascinating, the history of neonatology. But it was like sort of goes back to that. You don't know what this is until you need us. Yeah. And it was the same in research and money. So until a U.S. president's son died,
essentially,
was when we, really got kickstarted. And
on
surfactant,
this incredible drug.
It's probably been the most revolutionary in terms of saving babies' lives.
Wow. Wow, that is crazy. So when you talk about, for those that don't know, what are the different assistant breathing?
So the most invasive breathing is a breathing tube or an endotracheal tube that goes either in the nose or the mouth and goes between the vocal cords and sits in the trachea. And then you're attached to a breathing machine, ventilator, that helps. So there's many different modes and types of ventilator. And we use all of them depending on what the baby needs or the adult needs, because it's the same in all areas of medicine.
Absolutely.
So how much support they need really dictates the mode and how much pressure, and then we can deliver oxygen mixed in with the air. So delivering gas that way. And then the next is non-invasive, which is really our primary mode. So a lot of people would be familiar with CPAP for sleep apnea. So we use CPAP, but it's only a mask on the nose, not like the whole face like adults wear. And bigger kids wear. And so we have different modes of that as well, but it means that we don't have anything inside of them. It's all on their face and outside. And sometimes we can actually even still feed babies on it, depending on how much support they're on. But it's much more gentle. Babies are doing all the breathing by themselves most of the time.
They're not relying on that tube. And you wean. So you kind of, if you were, I remember with Gwendolyn, when she was intubated, then she would wean to the CPAP, and then from there it was the high flow.
High flow or just low flow, so oxygen, so not pressure blowing down into the lungs, but just air,
just not having to work so hard with everything. Interesting. What are some of the common conditions that you would see a baby have or maybe develop within the NICU?
So if we're talking about prematurity, there's we go by systems. So we've been talking about breathing, so we can start there. So every baby has what's called respiratory distress syndrome.
Okay.
We sort of say that's the disease of prematurity,
Yes.
breathing disease of prematurity. So we treat it by just giving them the breathing support that they need. So whatever they need, and including that surfactant treatment. Then a lot of babies who are born extremely premature, they have to still have oxygen when they go home.
Yes.
So that's pretty common. But what's nice about respiratory distress syndrome and what's sort of the evolution of that is BPD or bronchopulmonary dysplasia is it gets better.
So as they get stronger,
as
and
they
older.
grow lungs and their lungs regenerate and they develop normal lungs.
Yeah.
So it really, like, as they get older and grow and have proper nutrition, they have normal lungs. So they don't all have asthma. They're not on oxygen forever. So it gets better, which is really what is so amazing as well about
the evolution
babies.
of lungs.
Yeah,
Essentially.
absolutely.
Wow.
Mm-hmm. So breathing, and then you've already talked about sort of Gwen having a brain bleed. So one of the biggest risks is the bleeding in the ventricles or the spaces of
And
the
why
brain.
does that happen? Because the ventricles aren't totally developed.
So sort of like everything is there that the baby needs, but they're not developed to be sort of ready to be born.
Absolutely.
So it's mainly where we get a lot of our consequences is from the blood vessels. So the blood vessels in those spaces in the brain are really, really fragile. So when a baby is unstable or really sick from something else, or really their body is really stressed, those blood vessels can just pop and bleed. So that's what the intraventricular hemorrhage or IVH comes from.
Okay. And what I've seen as well, because with the constant MRIs and stuff, is how amazing the brain is and the way that it can absorb and repair itself. Not repair essentially, but I guess what is the word that I'm looking for?
Well, it gets rid of that blood.
It's able to, it's heal in that sense. I mean, there is likely some damage depending that, you see later on in life, maybe. But the way it is to accommodate.
Yeah. So that's called neuroplasticity.
Yeah, we love that little sponge, right?
So yeah, and it's why it's so amazing to do this too, and why we never can say, no, Gwen will never be able to walk. She'll always need a wheelchair or something, because we actually don't know what the brain will do and how it will respond. And that's what it does, is the other parts of the brain that wouldn't normally be in charge of walking or running, they take over, and they do that because they know that that part has been damaged or is missing. And adults don't have the same degree as that. So that's why, after an adult has a stroke, they're not able to regain the same way as a child. Wow. So it's fascinating, really. But all the other consequences come from blood vessels too. So same with her eye exams, all of her ophthalmology exams. So retinopathy of prematurity is just a fancy way to say that those blood vessels don't develop in the back of the eye properly. And then when they do start to develop, they can go crazy and need to be treated. And then same with the gut. So feeding, we have to feed really slow because the blood supply to the gut is so sensitive. And Gwen had other issues because of her TEF. So feeding was always going to be a major milestone for her.
So those who don't know, and if you're just listening for the first time, Gwendolyn was born essentially unable to swallow. News to me, I had no idea what it was. But it's a condition where essentially there's different types. Is there four different types of TEF? But it just means that the top part of her esophagus was a dead pouch. So it wasn't attached to her stomach like it usually would. But her stomach piece was attached to her windpipe, which obviously will cause problems if not treated. She wouldn't be able to live without it being treated. So super crazy. And it was quite amazing to see, once we were past that gag reflex with Gwendolyn, it was constantly anything and everything she could get her hands on. But yeah, just seeing where it started to where it ended up was incredible. Miracle. So I guess, how do you approach the care of extremely premature babies? We talked a lot about, what you would do with breathing support, but what about, handling?
So that's actually a great example of what has changed.
Okay.
In just the short time that I've been in this specialty is, so when I was in medical school, 25 weeks was the absolute limit. And now we're resuscitating at 22.
Okay. So not really that long ago.
Absolutely. And even some in Canada, our numbers are still quite low at that gestational age.
Yes.
But in countries like Japan, their outcomes for 22 weekers are equivalent to our outcomes at 23 and 24 weeks. Wow. So there is a way to do it successfully, and we're still trying to figure that out. But yeah, handling is so tricky at the really, really small ages because the skin is not sort of thick. So they're almost transparent and soft, sort of not gelatinous, but kind of like just so fragile.
Yes.
And it takes about 2 to 3 days for the skin to sort of harden a little bit.
Yeah.
But as you can imagine, when a baby is first born or anyone who needs a lot of medical support, they've got stickers everywhere. They've got IVs. Everything is stuck on their body. So that's the biggest thing with these really extreme babes is trying not to damage that skin and cause more trauma. So we actually have special sort of sheets we'll put on the bed. We try not to put anything on their skin. So we'll just use the SAT probe, which is like a little soft Band-Aid.
Yes.
And even IV lines, we'll only use the belly button and not tape anything in. So it's just sutured.
Right. I remember the belly button.
Yeah. Mm-hmm. So we try to do things a little bit different. And then we call it in Kingston, the small baby bundle, but it's basically like limited handling. So every time you open the door to the isolette counts as a handle because it's disrupting them. They're so sensitive to sound and light.
It's a shock.
Well, they're not supposed to be out.
No.
So everything is a shock and new and scary. And we're also learning that too about how they're processing all of this sort of external stimulus. Mm-hmm. And that's where a lot of the evidence and sort of work is around pain because they don't know that it's not pain. So trying to make sure they're getting positive touch as well, which is why that kangaroo care is so important because they know that is positive, loving, caring touch.
And kangaroo care is like the skin to skin, the tight hold, essentially. Mm-hmm. I mean, so great for parents, but also so important for little babes as well.
Absolutely. Mm-hmm.
Yeah, because you don't, I think there's so many things happening medically, but what is happening psychologically for them?
And we'll probably never know.
No.
We make assumptions, but after, maybe if you think back and try to remember after being in the NICU for 2, 3, 4 weeks with Gwen, when you did go in and handle her, if you touched her feet, I bet she pulled them back.
She did, yeah.
Because we do blood work off the heels.
Yes.
And that will always be painful. Her feet would always be sensitive,
Absolutely.
Right? So they're learning that.
Yeah.
So making sure that we're sort of counteracting that with positive
desensitizing
touch.
that too, right?
Mm-hmm.
Interesting. I am learning are you learning so much right now, Joey? I am just taking this all in. This is insane. When it comes to like parental guidance and support, because we know in the NICU that you're not just working with the babes. I mean, you're also working with the family super, super close. What advice do you have for parents of premature babies who are just trying to get by and cope with having, their child in the NICU? It's
so hard because I have 3 kids, but none of them have medical problems, thankfully. I actually tried to bring my babies after I had them to the NICU because I worked there and they all knew me and I just wanted to sleep and they wouldn't let me leave them there.
Yeah.
But, I think the parents that I see that cope well have strong social support systems.
Oh, it's community, really.
100%. And I think that, whatever I say or do is not going to be giving you that.
Yeah.
So it's really having something that is going to be an outlet or support for you, and whatever that looks like.
Yeah.
So I remember you came in and you had so many family members, and you're so well supported, and it would have made all the difference in the world. Even I remember family meetings, you have your parents there every time.
Yeah.
Even just because you're so incredibly exhausted in those first couple of weeks that you're not going to remember anything anyone said. Like, so
I have
you
a
need
journal, but
someone
half the
there.
time I wasn't writing in it. I'd be like, okay, what did she say again, Mom? You know,
exactly.
Yeah.
So even just having someone there for those first couple of weeks, but you know, I think with a preemie, you're there for so long.
Yeah,
and it's figuring out a way to debrief about that too, or have a routine that you know is going to fulfill whatever that need is in terms of your visiting and your sort of concept of family.
Yeah.
So many families also have other kids at home. So they're so conflicted in terms of, well, do I go to the NICU before I put my kids on the bus, or do I go to the NICU after? You know, I also only get so much time off for EI and mat leave. So do I go back to work while they're in the hospital and then take my mat leave after?
Yeah.
So there's so many different layers to that, but there are some really good supports. So speaking just about Kingston, if you're not sort of in a commutable location from Kingston, we have an amazing organization called Almost Home.
Yes.
That's basically like Kingston's Ronald McDonald House, but not Ronald McDonald. It's called Almost Home. And it's your home away from home. And it's used by many, many of our families.
Because you guys are the place. You know, you are what, level 4?
So level 3. Level 3 is the highest in Canada.
Sorry, level 3. And so a lot of babes, I remember, coming from all around.
Yeah. Well, even this weekend, I was on call this weekend and Ottawa was full. So we were getting babes from Timmins and we were getting pregnant moms from Ottawa.
Oh my gosh.
So I'm like, you could only imagine, you know, if you have a 24-weeker, like we're not going to move that baby until we can almost guarantee they're going to tolerate a move.
The big move.
And so, you know, that means you're now staying here for possibly a month or 2.
Yeah. And there goes your resources, your family, your bed. Like I didn't realize how much my pillows and my bed meant to me. I mean,
you sleep different at home.
Yeah, and I stayed for you know, a short period of time at Ronald McDonald, and then we were kind of shipped back and forth a few times, and then COVID had happened, so we had to, you know, bunker up at a hotel on Yonge Street, and you were at a hotel. There was no microwave. There was, nothing. I mean, even to have a toaster was frowned upon. Like, so you're so away from, you know, and I think the reason why, thankfully, that we were sent back the first time is because of the situation going on outside of Gwendolyn, but we weren't having the procedure right away. So thankfully they were like, no, we will ship you back so you can be around
you don't need
your
to
community.
Live here.
And it was family. Like you guys were family to me. I remember going to sick kids and me questioning, like, why are you doing it that way? Kingston doesn't do it that way. And they kind of look at me like, okay, Kingston, we're sick kids. But you just, and I think it is so true. Like those first few weeks, you go into shock to protect you. And it's just, especially walking into the NICU for the first time as a first-time parent, it's so different. And I think, sorry, I'm getting a little emotional, but knew this was going to happen. They don't, for me, and like I've talked to this about my friends too and what they went through, they don't really prepare you. I mean, even if I don't think you can be fully prepared, but they don't really talk much about prematurity unless you are at high risk. And for me, it was so crazy that I went in
you
to
weren't high
premature labor.
risk
I wasn't at all. I
Yeah.
had a very healthy, well, for me, it was a very healthy pregnancy. I
Yeah.
mean, I was at the gym the day before. I was with my OB an hour before my labor broke. She was like, what the hell happened? Like, I don't even know. And I remember I'm still trying to make sense of why did I go in? Because even with her condition, there was babes that went full term with it.
Yeah.
You know, so why this happened, I really don't know. But it just puts things into perspective that you could be good, but things can change very quickly.
Yeah.
Right. And I think if I was prepared a little bit more by my doctor, or, you know, maybe my OB at the time, I would have felt a little better. But so I guess as a parent standpoint, that maybe could be something we could improve on, I guess. But
yeah, because we don't like to say anything unless
you don't like to jinx
we think
it.
it's going to be a possibility.
Yeah.
But then also, like, I get asked to talk to a lot of moms who come in with threatened preterm labor, or maybe a little bit of bleeding, or maybe their blood pressure is a little bit high and they're, you know, between 22 and 26 weeks. And a lot of the time I'm sort of like, you really want me to go in there? Like, I am just going to stress them out so bad.
But I think it's the desensitization, you know, okay, this is what I could go into and this is what it could look like.
Yeah.
I remember saying to the nurse, and God bless her, but I'm like, this isn't my plan.
Yeah.
This, like, get me the fuck out of here. And she goes, there ain't no plan.
Yeah. Everyone who has a plan ends up in the NICU.
And I'm just like, I'm 20 and a half weeks though. And she goes, we've delivered sooner. And I go, well, what are the possibilities? And she's like, well, premature lungs. This is what the steroid shots for. Turn around. And I'm like, what? You know, like, it just happened so fast. And I remember the NICU coming in and talking to me about what to expect, but I don't even recall any of it, because at that point I was just like,
this isn't happening.
I am faint. I am ready to puke. I am ready. You know, I just want to get the hell out of here. Like, what is going on? Yeah. Like, get me off of this high, this cloud, whatever it is. I don't want to be here. But yeah, it's just like, you know, and I think that's why we really try with this foundation is spreading awareness about, you know, that you don't realize how common it is until you are in it. And no, not everyone is 20 and a half weeks like Gwen, but there are a lot of different circumstances. And one preemie babe is one preemie babe.
Everyone under 35 weeks is premature.
Yeah. Yeah.
Which is 1 in 10
There's a
babies.
fact, guys. Yeah. 1 in 10. That's not a lot. Okay. So we discussed that. We'd like, see how easy this is. We're just flying through this. She was nervous, guys. She neonatologist. Get that? We made her nervous. What are some of the ethical dilemmas that you face, if we can touch on this a little bit, in the neonatal care, and how do you navigate those ethical decisions?
So there's a lot of ethics in neonatology as a field, and a lot of it is all just stemming from decision making.
Yes.
So the sort of nitty gritty of it too, you know, luckily we live in a place in Canada where women's rights are valued and women can make choices if they are pregnant, and there's no limit on gestational age for that. So if you were, you know, God forbid, 38 weeks pregnant and getting an ultrasound and being told that your baby has a severe, you know, fatal diagnosis, you could have an abortion. Okay. So there's many places in the world where that's not an option.
Oh my goodness.
So I think, well, we can't sit on this couch and talk about decision making in babies without talking about women's rights and women's health. And I think that's really important to know in Canada, that you always have options, and you're always going to be supported and respected for that.
And I think that, I mean, like you said, it's not just when it comes to the baby or a preemie, it's that, you know, if you are pregnant, you have a decision. Yeah. Which is incredible that we are where we are.
Oh, 100%. Yeah.
I couldn't imagine being there and hearing that my baby has no heartbeat, but you need to carry for the next so and so
Until you go into natural labor.
Until you have natural labor, only to, like, that's so traumatic. That's so traumatizing.
It's terrifying, really.
Wow.
So very happy we don't have to deal with that in Canada.
Absolutely.
But minors don't have decision-making capacity. So all of my patients are obviously minors. And so their parents are their decision makers.
Okay.
So it's really our job to make sure parents are informed about what the options are and what the sort of goals of care or action and decisions are going to be. So a lot of the conflict usually comes around that. Parents want something different. But I think that it's our job to ensure that we've communicated that and then supporting the parents in what they want.
I know for myself, later we were there, 170 days. So I learned a lot while I was in hospital. But I know talking to parents too, or, if they seek my advice, like, what would you do in this situation? And I even told the first year med students is kind of referring back to that BRAIN acronym where, what are the benefits of the procedures?
Yep.
What are... if we don't do anything, what is that resulting in? What are the risks involved?
Yeah.
So just kind of looking at that and just even having a visual, I think, and being like, okay, what could we resort to is less intimidating because it's fucking intimidating in there.
Absolutely.
It's
And
terrifying
especially,
at times.
a lot of our families are from all different sort of walks of socioeconomic class. And there's still that sort of old concept of like, oh, well, the doctor said this, so this is what we're doing. And medicine has really evolved. I think, I hope, I want to believe that that's not the case. I'm just delivering information and I want to help you get to a decision that is
that
in
values
line,
you,
with your values and your people
beliefs.
At home and who's in your house and who's going to be participating with you in this. And that's really evolved a lot and really been something that I try to practice all the time.
Absolutely.
But it's also, it's hard too, though, because I've never been in this situation, but I have put a lot of parents in this situation and I need you to say the words.
Yeah.
I can't say the words and then you say, okay, like I need you to say, I am, yes, I want to take the breathing tube out.
Okay.
Right. Or I want it's all in how you word it.
Yes.
And I think everyone has I know everyone has different styles, but I think that, it's so traumatic already. So I usually frame those types of discussions with, I recommend, I think it's time to do this.
Yeah.
So sort of like what Desiree said, like you want to just hold her.
Yes.
Because if you just hold her, then I'm taking the breathing tube out and we can't do chest compressions. We can't do anything else and she will die.
Yeah.
So making sure people understand that.
Yeah.
Because no one wants a baby to die in a bed alone.
Oh, absolutely.
You want them to be held and surrounded by love.
Yeah.
And that's how it should be.
Yeah.
And so we try to facilitate that how best we can. But I can't be the one that makes that decision. And so putting the weight of that on a parent is also just incredible.
Mortifying. Yeah.
And parents sometimes can't do it or don't want to do it. And then in those cases, we do use heavier worded language, I suppose.
Yeah.
But most of the time we've been able to get to a place where I can say, I recommend it's time that now we shift our gears and this is what we're going to do now.
And I think just being able to digest it too, like it's just, I mean, if you ever, I don't think you'll ever fully digest what you're being faced with. I'm learning, but in those intense moments, right? Because again, your shock hits you and you're just like, I'm not registering. I'm not understanding.
Yeah.
That's extremely hard.
But I would say those are the dilemmas. Like when we're, I have had to call ethics once
Okay.
to participate in assisting us with a family.
Yeah.
So the only other times that, classically come up are Jehovah's Witness. So their
Okay.
beliefs that they can't receive a blood transfusion.
Oh.
So every single extreme prem needs at least one.
Oh, absolutely. I
So
think Gwen received 8.
Yeah. So it's so common. So that's sort of a really big one in our world with the Jehovah's Witness. And then, it's usually all around treatment decisions.
It's so hard because ethically, like, no, they need this, that this is the right thing to do. But we also want to respect how, you believe and bring in those things too. That is really hard. Oh man, that we actually had Jackie on. She's a wonderful do you know Jackie?
A little bit.
Yeah. Okay. So she was really faced with a really hard decision too, being a naturopath doctor, and then her son having cancer, and then being faced with he has to have chemo. And now she knows reasoning why, but at first it's just like, but I feel like my whole my rights are taken away from me in a sense, right?
Yeah,
So,
you feel like you don't have a choice.
yeah, you don't have a choice. Yeah, absolutely. Man, we are just flying.
I think I
through
prepared
this.
a different answer for that question, but now I can't remember.
No, it's
it.
okay. That was perfect. I think that was so good. I mean, again, you can't predict what the future holds, but what impacts does long-term NICU stay have on the development of infants, do you think?
A lot.
Yeah.
A lot.
Yeah.
But it's not even just on the baby, on the family.
Yeah.
Money, like marriages, relationships. Like it's so I shouldn't say so common. There's at least 5 families I could tell you in the last 3 years who've had babies in the NICU that have split up.
Everything is so hard to begin with when you have a newborn, because it is such a shock to your daily routine.
Oh, and if you have different ways of coping, it will tear you apart.
Oh, absolutely.
And we see it. We see them fight. We see them argue. Like it's heartbreaking.
With medical families too, because now you're a medical family essentially. Like you're not just let go when you leave the hospital. And I learned that quickly. Like you're followed by a lot of specialists for checkups, which can be very difficult too.
Life. Yeah. Oh, absolutely. And just being able to manage that. But no, I had one mom say to me a couple weeks ago, I was like, we do have almost home. Like, you don't need to be commuting. They lived in, I think it was Brockville. So not so far, like 45, sort of 55 minutes.
Still like
and
an
she
hour
said,
there and
no,
back.
we're driving because he has to drive me, her partner, and because I can't drive because I had a C-section. And it's our time to talk. She said, and then when we get home, it's done and we can be sort of quote unquote back to normal.
Yes.
She said, but this is how we're coping right now.
Yeah.
And I thought that was a great idea.
Absolutely.
I was like, you're stuck in the car. You don't even have to look at each other,
No.
but it's going to be silent or you're going to deal with whatever you got to deal with.
Absolutely. You're going to unwind, right?
Yeah.
However that may look.
Absolutely. Yeah.
Wow. And it is. No, it really is. Like I felt like, I pumping every 3 hours. And for me, pumping was so important because Gwen was so sick. That was the only thing I could do for her, so it was so important that I was able to pump, and just being there. Like you just, so much as when you don't receive that first initial baby placed on your chest, like you just want and dreamt of your whole pregnancy, and for them to be just whisked away, it's only to not know, and big chances that you're not going to be able to hold them, like you said, for a little while anyways, and not being able to bring them home. There's so much uncertainty. So I guess like just it really does play a toll on yourself, on who you are. You're not the same person when you walk out of that place.
But you're not the same person after you become a mom either.
No, absolutely not.
That changes you greatly.
Oh, absolutely. But like, who signed me up for that?
Yeah,
like
the trauma of becoming a medical mom.
Yeah. Yeah. And just again, like medically complex moms too. Like you said, it never leaves you. It never goes away.
No.
So.
But no, the longer length of stay the worse outcomes for everything.
Absolutely.
Is what the literature says. In our country, it also means more expensive.
Okay.
In the United States, their length of stays are shorter because people have to pay for it.
Yes.
So more families will go home still on caffeine. So we use caffeine to treat breathing spells or when babies hold their breath for too long.
Yep. Kind of stimulates them a bit.
It 100% is a brain stimulator, just like the way
absolutely.
we use
the
it.
Caffeine espresso
Babies
hit
get
me
it
up.
too.
Yeah.
And so that we in Canada, our practice is not to send babies home until they've been off it with no breathing pauses for sort of 5 to 7 days.
Yes.
But in the United States, they send them home on it because sometimes that'll prolong your stay by 2 weeks, sometimes longer.
What were those called again? Braddies or
Braddy DSATs.
Oh my
So A's and B's and D's.
Yes.
Yeah.
Yes.
So apnea, Braddy, and DSAT.
Yes.
So or a spell.
Yes.
So
those
spell
damn spells.
Yes. So in the United States, same with NG feeds. So they won't wait for them to be fully sort of feeding by breast and bottle or on demand. They'll send them home on NG feeds because, again, it'll save you probably a couple weeks, which is thousands and thousands of dollars
for them.
in the United
What is
States.
a typical stay for people in the States?
We all, from a counseling point of view, we always tell families, you're staying in the hospital until your due date.
That's right. Okay.
So that's what we tell people to plan. But as soon as you're over 35 weeks in Canada, I think it's the same in the States. It may be 34 weeks. And you're doing all the feeding by yourself, you're in a crib, sort of regular crib in regular clothes, I say, then you can go home. So that's, 5 weeks before your due date. But that's when we start considering discharge.
Considering it, yes.
So if you're born at 22 weeks, you're looking at 6 months.
Don't hold your breath when it comes to discharge. Trust me. Take it from a vet. Yeah. I remember, oh my God, Gwendolyn, she was always the worst for this. We were supposed to go home. We were supposed to be, I think we were discharged in June sometime. And we were actually supposed to go home before Mother's Day. And I always wanted to go home for Mother's Day. It was such a huge deal for me. And I remember I would advocate. I'm like, what about Mother's Day? Just like, want my first Mother's Day home. But she developed like a structure in her esophagus, which happens often with TF. It started to tighten again because when they went in to fix her anatomy, you're playing with anatomy. So that's, for her, it was not normal what they were doing. So her esophagus started to shrink again, which was causing, great problems. And we definitely couldn't go home like that. So I remember I held my breath the night before discharge. We were to go home and she had to pass the car test. I'm like, Gwendolyn, get your shit together. You pass this car test.
Give her a pep talk.
Oh, I would always give her pep talks. But this one in CERT, I'm like, look at me. Like, we're getting the fuck out of here. Like, we got to go home. And even the nurses are like, Gwendolyn,
you can do it.
Don't mess up. Yeah. And I remember, he came the next day, her surgeon, and said, so Gwen, how were we behaved? I'm like, yes, my dad's on his way. Like, he'll actually be here in about 2 hours. Yeah. He's going to conquer the Don Valley, an old school farmer. So when he's not turning around. But yeah, you literally are not leaving until you have those papers in your hand and you are out the door.
Actually in the car.
Literally. Yeah. Like actually out of sight and run.
Yes. I just had a vision of like your dad in an old pickup truck with like his 4-way flashers on, trying to drive through downtown Toronto.
Honestly, Gillian. And it's so funny because we were followed closely by sick kids and we would go up, every 6 months. Yeah. And he was like, no, I'm driving you guys. And it was the most miserable drive there and the most miserable drive back. Like road rage. He even hates going into town in Tanapani, which is super small, right? So he was convinced. He's like, no, I got it. And I'm like, Dad, like, the Don Valley. He goes, I know. But he'd get on there and he'd curse and swear and not understand anything. But
that's love.
That's love. And he actually came into appointments with me. I would pull the whole, during COVID, I'd be like, oh, I hurt my arm. Like, I need my dad to help me carry her. And
you knew all the tricks.
I was so tired. I know. And I'm like,
I can't come by myself.
But he was, navigating, sit there during specialist appointments. Didn't know what the hell anybody was talking about, but he was there to entertain. So
that's good.
I guess my question is, do you know how much a common, like a stay would cost a family in the States for NICU?
So it would depend on the gestation, right? Because
Yeah.
the younger you are, the longer you stay.
Yeah.
The sicker you are, the more charges there's going to be.
Absolutely.
But it's anywhere, depending on the level of nursery,
Okay.
it's going to vary. And in the United States, if whatever sort of group you're involved in, like how much they charge is what they charge.
Yeah.
So there's hospital charges. You'd get a hospital bill, you get a doctor bill. So from a hospital point of view, it's usually about $3,000 to $5,000 a day.
Oh my God.
And then the doctor bill is usually about $1,000 on top of that.
Oh my goodness.
A
day?
A day. In Canada, a level 3 baby is $3,000 a day. Like if you don't have OHIP and you come to the hospital, or your baby does, it's $3,000 a day. You will get that bill when you get discharged.
What a slap in the face. Like here, on top of everything you else have been, like you've been through, you owe this much. Wow. And again, another reason why I'm grateful to be a Canadian.
Absolutely. Well, yeah, people in the United States, they save to have babies after they save to have their wedding.
Yeah,
right?
you'd have to.
Because they also don't have this paid maternity leave.
That's right.
Some states do. I think California just brought it in.
Yeah.
But it's definitely not
Just
universal.
mind-blowing to me.
Well, and in
Mind-blowing.
Canada, we just went to 18 months. Well,
Yeah.
not just. It's been a while, but.
Yeah. Yeah. Which it shows like even improvement for development. I can't imagine going to work right after having a child.
I couldn't.
Yeah, I know. There's no friggin' way. Where do you see, like, I know we talked about, well, actually we kind of answered that already. We're just like flying through this. See, not so bad, eh? I guess like let's kind of talk about your personal reflections and advice. Like, what is one advice you could give to your younger self as a medical student going into where you are now, or to a future medical student that will be in your position at some point?
So I do. I have my medical students. I talk to them all the time.
You'd have to. It's a very hard
and
thing that you do.
It is. It's hard decisions to make. So usually when I talk to the students about trying to decide what they want to be when they grow up, because even though to get into medical school in Canada, you basically have to have a career in something else, and they're old and it's so competitive and it's wild. But I say, like, the first big decision is medicine or surgery.
Yeah.
So are you procedural based, where you want to be operating or doing something like that or not? And then once you've decided that, then it's sort of deciding what type of medicine or what type of surgery you want to do. So for me, like I said, I knew as soon as I walked into an adult hospital, like, barf, it's just gross. It's dirty. It smells bad. Like, I don't like it.
Icky.
I don't like it. But you walk into a children's hospital or a children's ward in an adult hospital and you're like, oh my God, like I just entered a different universe, or I'm in Disney World. Like it blows your mind how different it is.
Yeah.
And kids are, don't even know that they're sick.
Kids are so resilient.
And
that's what I've learned.
Like, they still want to play and they'll still make jokes and challenge you, and adults just lie there and whine and complain, and nothing's ever good enough, and it's just it's amazing. And so I made that decision early on, but then it was trying to figure out what type of medicine within pediatrics. And like I said, I like adrenaline. I like that sort of rush of having to make decisions sometimes quickly on my feet. And so that narrowed it down to pediatric ICU, neonatal ICU, or emerge. Yeah. And then it kind of came down to lifestyle and money. So in Canada, doctors are very well paid, but again, there's still a lot of variability between specialties, but they're still really close depending on where you work. And so then it was really lifestyle, and job availability in Canada. So we didn't really want to move too far.
Okay.
And
are you from the Ottawa area?
Nope. My husband and I are both from a small town in Nova Scotia.
Oh my God. Amazing.
So we talked about like going home, because where I live, there's no NICU.
Okay.
So I could work as a pediatrician, but not as a neonatologist. And actually in COVID, I thought about going back home.
Yeah.
my mom was sick at the time, and it was hard. Like, I kind of feel like Kingston is a really hard place to get out of and a really hard place to get into in terms of traveling.
Once you're in, you're in.
Yeah. So it was a lot. And with COVID and everything, we did sort of entertain it. But no, we stayed here. We love Ontario. We've been here for almost 20 years.
Wow. So it is home too.
Yeah, it is home now. And it's home for my kids. They don't know anything different. No. But yeah, with lifestyle, like, I don't think I could work in
because
shifts.
It's not a job that you just kind of clock in and out. It is a lifestyle. What you do.
100%. And even now, going back to like being in-house on call, like, it's a big shift in lifestyle. But
so do you have a place there where you like
we have a call room
up and settle and sleep, kind of like Grey's Anatomy?
And it's like on an adult ward.
Okay.
So it's like very hard for me.
Oh, you're like, fuck, here we are again.
I'm like, just don't look at them. Don't look at them.
Don't look at me. Put my AirPods in. I am not here. You do not see me.
But it's also like, I can't help you. Like, I know nothing about adults.
I literally have no
so
idea.
Long. Like, I'm not helpful to you. It's the same when they call for a doctor on an airplane. It's like, oh my God, don't
I know I have to ethically.
Someone
I have to show
else raise their hand. Anybody else.
I work with babies.
Yeah.
That's too funny. Can you share your most memorable experience when in the NICU?
I think what sticks out the most are the moral dilemmas or moral distress. So not always positive ones.
Yeah.
But I think the one that pointed me into the direction of my career is I had a young couple, and it was their first pregnancy and their first baby. And by young, I mean like they were 19.
Okay.
Like kids.
Yeah.
And so sweet. And they had no money. As Claire would say, they didn't have like a pot to piss in.
Oh, Claire.
And they loved this little boy so much. And he was 24 weeks, and every single thing that could go wrong went wrong. And he had severe brain bleeds on both sides. And after talking to them, like, they really sort of said, like, the picture we were painting in terms of consequences of prematurity, they didn't want for him.
Yeah.
And he was suffering. He was on a lot of pain meds. We really struggled with the breathing support. And so they elected to do withdrawal of life-sustaining therapy.
And that's comfort care?
Comfort care, yeah. So we extubated him. And we thought he would die really quickly. Okay. And we had a room, it was actually about this size, in the very back of the NICU. This was in Ottawa. And it had a pull-out couch.
Yeah.
And we extubated in that room with this young couple, and he didn't die.
He didn't
die for 3 days.
Oh my gosh.
And after the second day, the dad looked at me and he grabbed my hands, and I'll never forget it. It was just like that look in his eyes of the worst pain. It was like I was stabbing him in the heart.
This is
the way he was talking to me. And he just said, can you just do something?
Yeah.
Like, we thought he was suffering before. Yeah. And now he's suffering even more.
Oh my gosh.
And I was like, there's nothing I can do.
Yeah.
And at that time, we didn't keep their IV lines in. We didn't give them any medicine.
He was just, wow.
So he was suffering, absolutely suffering.
Oh my gosh.
And the parents were suffering, and everyone who went in that room was suffering. And it absolutely devastated me. And I didn't want to go in that room.
How helpless you would feel.
Didn't want to talk to them. And they were both smokers, so they would go outside to smoke. And after the second day, every time they went outside, they asked someone to hold him in case he actually died when they were gone. And so we passed him around, and everyone would hold him. We would carry him around, and he passed on the third day, and the relief, but the anger from them was just so palpable. And after that, I decided I was never going to let another baby die like that.
No.
Ever.
No.
So I did a fellowship in palliative care.
That's where that came from. Okay.
Yep. And specializing in neonatal and perinatal palliative care. So that's where also a lot of my sort of drive for really, strong communication and being a partner with the parents and not dictator is too strong of a word, but like I'm not in a position of power. I'm a partner in this journey and in this discussion and being able to alleviate suffering. Like no one should have to go through that.
Well, and witness it. I mean, you finally accept the fact that you're going to do this, that is going to affect your whole life. Mm-hmm. And then only for it. I mean, the questions would be like, did I do the right thing? Right. And even as in
they said it so many times. They said, so should we put the breathing tube back in?
Yeah. Like, are you sure this is the right thing to do? And for yourself too, you're probably thinking,
oh my God, what did we do?
Did I do the right thing? Because you're human. I mean, how could you, and I think a lot of people, I mean, for myself, I look at you as a superior, and I think that's just the natural thing for when it comes to medicine. Like you said, kind of back in the old days, that's the way it was. You listen to that. That's the way it goes. But now I think it's, it's becoming more of a personal thing. I know I've experienced, and a partnership, like you said. So you're human. You would feel for this family, you would feel for this child, and you're feeling for yourself. That's really intense.
So that is, and I was a resident at the time.
Oh my gosh.
So I felt like I knew, I kind of felt like I knew a little bit, but really knew nothing. And and I remember the neonatologist not going in that room.
Oh my gosh.
And I sort of said, like, I'm not going to do that.
That's what I'm not going to do.
I'm not going to do that. And as uncomfortable as it is for me, it's got to be a million times worse for the people in that room. Oh, yeah. So even if I can just be there, is important in doing something. So that would probably be one of the most memorable. And then Gwen is hard to forget.
Oh, Gwenny. That's what Bob said, when I went there for the presentation with the med students. He said, Gwen, there's premature. And then there's Gwen. Again, Gwen had everything go wrong times 10, with her condition. And he actually reminded me of same things that I don't remember, that, Gwen was close to death more than once.
3 times she coded.
3 times she coded. I don't remember that.
So one of them was in the OR.
Was that the first?
That was the first one. Okay. And then the second OR, I think it was the second one, I went down. Yeah. And I stayed in the OR the whole time.
Yes. I remember because you called me and I was at the hotel waiting to hear.
Yeah. And she didn't code, but she was
very
on the edge the whole time. Yeah. And then she coded at Sick Kids, didn't she?
Yes, she did.
Yeah.
I do remember that because I was holding her that day.
And that was supposed to be close to when you were supposed to go home, right?
Well, because, and I think
we heard everything. We followed her.
I lost my fucking mind that day.
She was as popular as a Kardashian.
Yes, I remember. And I recently shared that memory now that you're saying that. That was when we were due to go home. And what was happening was her esophagus was filling up with so much that it was pushing on her lungs, and her lungs were essentially closing and she couldn't breathe. And I kept saying this and I remember this one in particular surgeon, like I have a lot of wonderful people that I dealt with, but there were some that weren't very personal, and he's like, oh, she'll grow out of it. And I go, there's no fucking way she's going to be growing out of this. There's no way I'm taking my child home like this. And this is why I always tell parents, advocate. If you feel something, advocate. Your baby the best. And sure enough, I mean, this poor little nurse, I probably scared the shit out of her that day, but I just lost it. And I said, somebody get me a fucking person who can look after my child. Like, and that's not scared. Like, I lost it. And I remember a nurse came up to me and she said to me, I've been in your position before. This will not happen again. Yeah, you're right. She did. And she went limp. And that was, I mean, wasn't, to see where we are now, but no parent ever wants to experience that, or to be unheard or something for it to be prevented. Right. And that's when they, finally ran tests and found out that, this wasn't something she was going to grow out of, but more grow into. How do you maintain your work-life balance and and I guess the demanding of your job, but also taking off that white coat of a neonatologist?
So I'm definitely not the poster child for work-life balance.
Who is?
But as I've gotten older and my kids have gotten older, it's definitely become more of a priority.
Yes.
So not saying that my kids didn't need me when they were younger. It was
more of a
just
demand
different.
now.
It was
Yeah.
just a different kind of need. But I have like 4 calendars. I try to keep I'm super organized. So I try to stay on top of everything.
Would you consider yourself a type A personality?
100%.
That's why you and I get along.
100%.
Me too.
Like so bad. And then like I have a family calendar and my husband has a calendar. So we have a lot of calendars.
I love calendars. I love them.
And my calendar, my paper calendar in the kitchen wasn't big enough, so I bought a dry erase magnetic calendar that goes on the fridge, so they're next to each other.
All the visual prompts.
Yes.
Yeah.
But no, I guess now that I'm not training, because in training it's like impossible to have a life.
Yeah.
I have trying to make it more of a priority.
Good.
For sure.
Good. Because that way you're
and
not...
it's all the same things, right? Exercise, eating properly.
Yeah. All of those things we don't want to do, but we have to.
Yes. But what I usually tell people is like, it doesn't even have to be the right things.
No.
Just, it has to be something for you.
Yeah.
Something that's yours.
Yeah.
So if it's, maybe you love doing laundry.
Yeah.
Then go to your laundry room and stay there for like 45 minutes.
Too.
Like, I don't know.
Yeah.
Like, I don't mind doing laundry, but I absolutely hate cleaning. Like, I will never clean.
Yeah.
But I hate having a dirty house.
Yeah.
So there's like, I love to cook. So I will spend that time in the kitchen.
Taking that time to make a priority.
Yeah, and that's
absolutely.
a priority in my house, and food is a priority. And
I love that.
And so I think that's what I usually tell people. It's like, you just need a thing.
Yeah, one thing, and I think it's, for me, even in the depths of after Gwendolyn, I remember my dad coming in and he's like, just move from one room, even if you're just changing your scenery a little bit or getting your water intake, something so simple, but and a lot of the time we take for granted, but what a difference it can make, right? We're done.
We're done.
Do you have anything else that you want to kind of elaborate, talk about?
I don't think
so.
No, I don't think so. It's just it's really nice to hear you talk and your perspective, and I'm so glad that you're sharing your experience and knowledge and journey, and what you said about you telling people to be an advocate. I think everyone needs to know that and practice it. I think, we as the medical professionals, we know what we know, but we don't know you until you tell us. Yeah. And
it's so intimidating.
If you need a pillow, you just ask for one.
Yeah.
Don't suffer. It's even just those simple things. Yeah. But also, you really should understand what's happening with you. Yeah. It's your body. And so if you don't understand, you have to ask.
Yeah, absolutely.
And you're not being a trouble. You're not being a burden. It's our job to provide those answers. Yeah. And, we all have bad days, but I think it doesn't matter, and we're all busy. So make yourself a priority and be your best advocate.
Well, and I think that's just it too, because like you said, when your mind becomes a little bit less blurrier, you do know what you want, right? You those values, those beliefs are still a little bit there. And if you can dig into them a little bit deeper and find your voice, it can move mountains. And I found, once I found my voice, the outcome for Gwen's procedures, her admissions, those kind of things really improved, right? So when there was that receptive language between myself and the specialists.
And there's a lot of people that say well, I don't want to be perceived as difficult.
Yeah.
And I think we really need to get away from that kind of language.
You're in a difficult situation.
Because asking questions doesn't make you
No.
difficult. It makes you interested and curious.
Yeah.
And there's nothing wrong with that.
Absolutely. I forget the one time, but I remember Gwen went through so many, obviously complications, and she had a chapped butt. Remember that? No. Remember the chapped bump ordeal?
No, I don't remember
I was like,
that.
Bob, Dr. Connolly. I was like, look it.
Oh, he will never talk about bums.
And he's like,
Diaper
what?
rash.
And I was like, she's got a bad diaper rash. He goes, yeah, so? And I was like, what are we going to do about it? He goes, put some cream on it. Just like any just like any babe. Babes have diaper rashes to bear. And I'm just like, okay, you're right. That's right. But he appreciated that I was advocating for her, but he was like, that's not my problem. That's a you problem.
Yeah, exactly.
I love you guys. And it's just a full circle. I mean, again, from the first time that I met you, and I remember you coming in with your luscious red auburny hair and sitting down, and you're in the middle of the room with so many other people around you, and I'm just grilling you with this, pen and paper. I have to go and dig in the box because I still have the book, and, just researching and answering half these questions. I didn't even know what I was talking about, but to now, it's such a good experience, and I think we can cheers with that. And
absolutely,
thank you again for coming on with us and spending the time. We appreciate it.
Amazing. Thank you.